This is a podcast for Nursing 242 for induction and augmentation of labor. So, the rate of labor induction is certainly on the rise, partly because of patient demand and request, partly also because of the amount of comorbidities that patients are coming into pregnancy with now. So we have more patients coming to pregnancy with hypertension, diabetes, other health complications that would increase their risk of needing an induction. We do know that the American College of OB/GYNs has said that labor induction should not occur prior to 39 weeks without a strong medical indication to do so. So we should not be doing these kind of social or patient request inductions prior to 39 weeks of pregnancy. We always want to be looking at the risk versus the benefit and making sure that the choice that we're making is in the best interest of both the patient and the baby. There are pharmacological and non-pharmacological methods that we can use, which we're going to go over, and then we're going to talk a little bit about the role of the nurse. So we're obviously going to be an advocate for our patient. We're going to be educating them and informing them of the methods that we're going to use and the nursing care that that will entail. And we're certainly going to be assessing and caring for both mom and baby throughout the induction. So risk of induction or augmentation is going to be the same basically for all of the different methods that we talk about. So uterine hyperstimulation or tachycystole, so essentially too many contractions that, greater than 5 contractions in a 10-minute time frame. Fetal distress, that can be caused by the hyperstimulation. If we have fetal distress, we have an increased risk of needing to have a C-section, uterine rupture, placental abruption, and then what we call the cascade of interventions. So, like we mentioned before in the intrapartum podcast, once we do one thing to mess with the normal course of labor, more and more likely the patient's going to need more intervention. Pre-procedure, we want to make sure that the patient has been given informed consent by the healthcare provider. The patient should know why they're coming in for an induction. The risk should have been reviewed with them prior to them coming in. We're going to do teaching about the methods that we're going to use, any procedures. So things like if she is going to be only allowed to have clear liquids, if she has to be on continuous fetal monitoring, if there's anything special about the care that you're going to provide based on the method of induction that we're using. We should be assessing and documenting our reactive non-stress test before we get started as well. And then we're certainly going to assess mom, do a fetal assessment, and review the patient's H&P and make sure there isn't anything that contraindicates any of the methods that we're about to use. Patient should have a documented Bishop score as well. Basically, it's where we give the patient a score for their cervical exam. So we're looking at the position of the cervix, consistency, is it soft, is it firm, how dilated, effaced, and where the fetal station is. You can see on the side we also add points for things like preeclampsia or if they previously had a baby, and there are also reasons that we would subtract points for. Ideally, the Bishop score should be 6 or higher. Anything less than 6, so like 5 or below, there's a high probability that you're going to end up with what we call failed induction, or potentially the patient's going to be at a much higher risk for a C-section. Oxytocin or Pitocin, so the rest are going to be the same things we just talked about 2 slides ago, the tachycystole, fetal distress, C-section abruption, uterine rupture, all of those things. This is the one method that the one pharmacologic method that we can use in a patient who's trying to have a VBAC, but it needs to be used very cautiously in that patient population because it's going to increase their risk of uterine rupture. What we're trying to do is get these contractions to be fairly consistent, about every 2 to 3 minutes apart, or roughly 4 to 5 contractions in a 10-minute time frame. Water intoxication, which we've discussed before, is a risk, so we need to be on alert for that. Patient's going to need continuous electronic fetal monitoring. The oxytocin is going to be diluted in a bag and always run on an IV pump so we can titrate it up or down. So it's going to be the responsibility of the bedside nurse to be evaluating the fetal heart rate tracing, the uterine contractions, and determining, depending on the facility, anywhere to every 15 to 30 minutes, whether they should increase the oxytocin, leave it where it's at, or decrease or turn it off. Cytotec or misoprostol. So there is some controversy with using this because it is off-label use. If you guys remember back to when we were learning about it with postpartum patients and with bleeding, we talked about the risk of miscarriage when this medication is taken in a pregnant patient. Well, we're trying to induce or augment labor, so we're okay with the fact that it's causing uterine contractions and cervical change and those types of things. But the FDA considers it to be off-label use for labor induction or augmentation. So a patient should be appropriately counseled about that. We can, when we're giving it for labor induction or augmentation, we give it either oral or vaginal. Typically the first dose, the loading dose is 500 micrograms, and then it's 25, usually anywhere from 2 to 4 hours after that. The risk of Cytotec, so same as the other risks we've talked about. A drawback to using it is that, it's a pill, so we either take it by mouth and it's absorbed, or we place it vaginally, it dissolves very quickly. So if we don't like the pattern that we're seeing, we can't really turn it off or reverse it. It's going to be in the system until it runs its course. Then there is Cervidil or dinoprostone. So this is a cervical raping agent. So this is good for the patient who does not have a very favorable Bishop score starting her induction. If the Bishop score is not favorable and you use misoprostol or oxytocin, usually you're not going to get anywhere because the cervix isn't ripe and ready for labor. So that's what the role of dinoprostone is. So it's a vaginal suppository. It's placed back behind the cervix. It can stay in place for up to 12 hours. At the end of 12 hours, it's removed, the cervix is reassessed. If there's no change, a second one can be placed for 12 hours. In terms of monitoring, every facility is a little bit different. Some require continuous fetal monitoring with dinoprostone, some will allow intermittent monitoring. And the nice thing about this method is if we're seeing a pattern we don't like, there's the string that's attached to the medication wafer, so it can be removed pretty quickly if need be. Then there's laminaria. So these are essentially seaweed sticks that can be placed in the cervix. So if you look at the picture on the right, it shows the difference between what size they are excuse me, prior to insertion and then what they look like after some time. So what happens is they're placed in the cervix, and then it'll absorb fluids from the cervical os and will expand and will mechanically cause cervical dilation. This takes a really long time. As you can see the picture here, it takes about 24 hours for it to fully expand. So we typically don't use this for labor induction and augmentation unless we have a fetal death in utero. Other methods that can be used, we've talked about artificial rupture of membranes before as a method to induce or augment labor. Intercourse can sometimes be helpful for a couple of reasons. There are prostaglandins in semen that can help start labor, and then when a woman has an orgasm, it causes uterine contractions. Now, the body has to be ready for labor. This is why women can have intercourse during their whole pregnancy and not go into labor. It's only at the end of pregnancy when their body is actually ready for labor that it can be helpful. There are different herbs that are out on the market. Certainly, they're not really regulated, and the strength of the herbs can vary greatly, so it's not something we encourage patients to do, but they will sometimes purchase them over the counter and use them. Two of the more common ones are blue and black cohosh. Then there's castor oil, so women ingest this. Castor oil causes diarrhea, so when a pregnant woman has diarrhea, it stirs up prostaglandins, which can initiate labor. Also, they tend to get dehydrated with all the diarrhea that they're having, and that can cause contractions as well. It's not a very highly recommended way to induce labor because it makes the patient feel unwell, it dehydrates her, and there's also question about whether or not it can cause the fetus to pass meconium stool in utero. Then there's nipple stimulation. So we know that when the nipples are stimulated, it causes letdown of oxytocin, which can cause some uterine contractions. It's something that the patient can try, but it's not like she can really titrate it up or down in terms of getting the desired effect for contractions, because everybody's body is going to respond different. Then we have bulbs or balloons that we use. We can use a Foley or a Cook. The picture you see here to the right is the Cook catheter. And what we do with these, if you're in a facility that doesn't have a Cook, you can just use a regular Foley. The patient needs to be dilated about 1 centimeter. And we slide the catheter in through the opening of the cervix, and then we inflate the balloon with sterile water. And what it does is it provides pressure on the cervix from the uterine side and the vaginal side, which will cause the cervix essentially to mechanically dilate. We insert them, they can stay in place for up to 12 hours. Typically, they fall out before the 12-hour mark, and when they fall out or come out, the patient's usually about 4 centimeters dilated. It will slightly increase their risk of infection because you've got something indwelling in the cervical opening, and we don't place these once a patient's water is broken. She needs to have intact membranes in order to insert this. So this is the end of the podcast. You'll see there are some review questions here at the end that you guys can go over, and then we can certainly discuss the answers to these in the classroom.